Greetings, Dr. Dave here with Healthy But Whole. Today I'm going to be going over the DAPA-HF clinical trial. DAPA-HF is the abbreviation given to the dapagliflozin in patients with heart failure and reduced ejection fraction trial. The study citation is given here across the top in AMA format with a primary author who is called McMurray. Purposes and backgrounds was to investigate SGLT2 inhibitors and treatments beyond type 2 diabetes. The reason that they were investigated in this manner is that they were shown to have potential for preventing heart failure development in trials for type 2 diabetes. So this means that in these trials where they're establishing safety and efficacy for patients with type 2 diabetes, there was a lot of data hinting that there may be benefit in the prevention of heart failure. So trials like DAPA-HF, which we're looking at today, were thereby conducted to prove that theory. The mechanism of benefit was attributed to a diuretic effect of these treatments. These SGLT2 inhibitors can be seen with mild diuresis, causing increased excretion of water, and in heart failure that would lead to reduced symptomatology, as well as a variety of physiological effects. Let me scroll over so you can see these, and I don't know how to do that. The physiological effects include, neutralization of myocardial metabolism, ion transporter neutralization, fibrosis, and various vascular effects. I don't think anybody would ever expect you to really understand the physiological effects within the cardiac muscle because it's still something up to debate. Within HIF-REF, I would say that this is an underserved disease state, and these patients are severely burdened with severe cardiopulmonary symptomatology, just meaning that there's not a ton of treatments that really help these patients live wonderful lives, especially at the time that this trial came out in 2019, and really a lot of need to help prevent the further decline of these patients' well-being. And so the objective of this trial, as I've kind of alluded to, was to establish an understanding of the treatment effectiveness of SGLT2 inhibitors, specifically dapagliflozin, in patients with HIF-REF. And so this historical context, you could put all those diabetes references that I listed. Study funding and design is summarized here. So it was a multinational, being 410 centers in 20 countries, randomized, placebo-controlled, parallel group clinical trial. The primary funding was through AstraZeneca, as they were the primary sponsor. Each site had an independent IRB, which means that they had their own ethics board controlling who gets in, who doesn't get in. Is the trial conducted on an ethical standing? And each processing step was conducted under the guidance of an independent data and safety monitoring committee. So these committees just make sure that there's no foul play in the processing of any data related to the trials. The population inclusion criteria included those who were greater than 18 years old with ejection fractions less than 40% and an NYHA classification greater than 2. Just to briefly remind you, NYHA greater than 2 basically just means you're at least having some symptoms with activity. BMP levels were also used to include patients, so either a BMP greater than 600. They lowered that criteria to greater than 400 if you'd been hospitalized within a recent year. Or they raised it if the patient had comorbid AFib. They also had to be on device and or drug therapy, and the drugs included ACE, ARBs, or ARNIs, beta blockers, and mineralocorticoid receptor antagonists were encouraged but not required. Exclusion was recent SGLT2 treatments and or prior adverse effects of SGLT2s, type 1 diabetes, hypotensive symptoms, or systolic blood pressure less than 95, an EGFR, a glomerular filtration rate of less than 30, heart failure hospitalization within the last month, or a current decompensation of somebody's heart failure, ACS, so acute coronary syndromes, including heart attack, unstable angina, strokes, or TIAs within recent 3 months. So the interventions following a 14-day randomization, screening, and baseline data collection period had randomization per a stratified protocol, stratified based on patients' demographics, essentially to kind of even out the different groups for what sort of criteria somebody may push into either direction, comorbid diabetes, their baseline heart function. And they were randomized to dapagliflozin 10 milligrams or placebo. Following this randomization period where they started their med, they were seen 14 days, 60 days, and 4 months intervals thereafter. At each of the follow-ups, the patients were assessed for heart failure symptoms related to volume status, any adverse drug effects from taking the treatment, their current renal function, and potassium levels. The primary outcome within the trial was a composite of worsening heart failure, which they summarize as being an unplanned hospitalization or urgent visit requiring IV treatment, or cardiac death. Secondary outcomes include a composite of heart failure hospitalization, cardiac death, so looking at each of those components individually, hospitalization frequency, a change in KCCQ, which is some abbreviation that just means cardiac symptoms related to heart failure. A higher score is probably better. Renal function change or renal death, and all-cause mortality. Safety endpoints include all of the adverse events you may expect with this drug. So things they focused on in the trial were volume depletion, renal events, hypoglycemia, bone fractures, diabetic ketoacidosis and amputations, gangrene, and notable laboratory findings. The trial was conducted on an intention to treat protocol, which means all that were enrolled were included in the sample characteristics and assessments. Sample size calculations were performed at a hazard ratio detection of 0.8 with a power of 0.9, alpha level 0.05, equating to 4,500 needed enrollees over a two-year anticipated follow-up period. There's all sorts of statistical data or summaries here. I'm not really going to go through them because I don't know how to explain them in a way that makes a lot of sense. Results. So if you look at the study sample, they recruited a sample size of 4,744 patients. 2,373 of these patients were randomized to dapagliflozin, the remainder to placebo. I've summarized their average characteristics here, which can be seen in Table 1 from the trial. On average, these patients were 66.3 years old, 23.4% female, an average BMI of 28.2. Whites encompass 70.3% of the population, North America 14.3% of the population, yada, 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 mostly NYHA2, heart rate 71, systolic blood pressure 121, an average left ventricular ejection fraction of 31.1, EGFR above 60, comorbid diabetes was present in 41% of patients, AFib in 38.4. And if you look at the meds, you basically are going to see that it was pretty much the GDMT for the time for heart failure. GDMT means the guideline-directed medical therapy. Currently, you'd see ARNIs way up higher on the list because ARNIs in the trial have really shown to be the front line for ACEs and ARBs, superior to them. So now ARNIs are being pushed. So we'll see that number start to creep up over the coming years, and digitalis will probably keep falling down. So actually looking at the outcome data, so for the primary outcome, which was that composite of heart failure events and cardiovascular death for dapagliflozin versus placebo, there is a hazard ratio of 0.74 with a confidence interval that doesn't cross 1 and was statistically significant. Here on the left, you can see the Kaplan-Meier curve that relates this to time. So this hazard ratio implies that the treatment is protective against the primary outcome and it is statistically significant. Secondary outcomes, we see similar trends with heart failure events, cardiovascular death, change in KCCQ score, so scores were improving on dapagliflozin. Renal decline was less frequent in dapagliflozin, which makes sense if you think about the kidney utilization of SGLT2, kidney disease of SGLT2 inhibitors, and all-cause mortality. Lab findings, summarized in Table 2 as well. We saw a drop in A1C, which makes sense, an increase in serum creatinine, increase in hematocrit, BNP had gone down, the overall mass of the individual on a kilogram basis had gone down, and SBP had also gone down. All of those very reasonable when you think about the mechanism of this drug. Subgroup analyses showed that there were some groups within this primary outcome that were non-congruent to the primary outcome data. So non-congruent means that these individuals did not have the same statistical significance that we saw in the overall data. That includes females, Blacks, those in North America, individuals at NYHA class greater than 3, and those without prior hospitalizations and comorbid AFib. So just always, take it with a grain of salt when applying these data to those patients. Adverse events for dapagliflozin versus placebo are in the table 2 and also in the supplementary appendix S1. Volume depletion occurred more often in dapagliflozin. Renal adverse effects actually occurred more often in placebo. Fracture was the same, amputation was the same, hypoglycemia was the same. For severe adverse events, severe depletion occurred more often in placebo, and serious adverse events for the renal function occurred more often in placebo. And again, that kind of makes sense when you think about the fact that SGLT2 inhibitors are now frontline in kidney disease. You're going to see beneficial renal effects. Treatment results, so this is kind of something I include in my journal clubs to just kind of address pharmaceutically how they worked. A medium follow-up time of 18.2 months was seen. Discontinuation rates of treatment for dapagliflozin was 10.5 and for placebo was 10.9, and there was hardly anyone lost to follow-up. So that strongly implies that there's not very high likelihood that this is a problematic treatment for patients. A very general summary is that dapagliflozin is statistically superior to placebo for a reduction of a composite of heart failure and CV death in patients with HIF-REF, with or without diabetes, which was the whole purpose of their trial. Other significant benefits are seen in the secondary outcomes of the KCCQ score improvement and the lab values I've listed here. I do want to go over some strengths and limitations, just so if you're writing a journal club like me, you can steal mine. Oh, give me 1 second. Okay. So strengths, I think these are relevant outcome measures. When you have patients with heart failure, looking at things that are going to kill them, put them in the hospital are probably the most important. Direct guideline on clinical practice, and here I've actually just cited the most recent heart failure guidelines, and also relevant GDMT, bar ARNI. So they can't time travel and know that ARNIs are going to be superior, but besides that, they did have a really good grasp of the guideline-directed medical therapy and tried to reflect it in their conduction of the trial. Limitations is that the demographics lacked women, Blacks, and those of advanced age at statistically significant amounts to make any sort of claims. There's an argument that there's a confounding effect of placebo versus the anti-diabetic, diuretic, and nephroprotection effects of dapagliflozin. Obviously, it's a critique that anyone can throw out, and a solution doesn't really exist because you would have to put somebody on a mild anti-diabetic, diuretic, and nephroprotective medication. However, there's not just standards of care that meet those criteria, but nonetheless, you could always say that the benefits seen in dapagliflozin are due to these effects, which it's an argument to be had. There's also a lack of data collected towards the GI and GU complications. Super buried deep down in the supplementary appendix, you could see some incidents of UTI that are pretty comparable between the two groups, but I think it should have been focused on a little bit more. Exclusion of those who are decompensated, hospitalized, or with recent acute coronary syndromes. And I actually wrote this journal club while on rotation within a cardiology unit. So obviously, for that sort of unit, we're excluding every patient we're taking care of. The author concluded, basically the summary that I listed above, that this is a better treatment than placebo for this composite of heart failure and death, and in the presence or absence of diabetes. My own personal conclusion is that it has to include this word symptomatic HIF-REF, right? Because if you're saying NYHA class greater than 2, you're not looking at NYHA class 1, and those are those who are asymptomatic. And if you look at the AHA, ACC stages of disease, this kind of leads to the exclusion of using this treatment in patients that are stage A and stage B, being those who are not yet symptomatic for heart failure. So stage B of the AHA, ACC guidelines is, LV dysfunction following a heart attack. It's one of those patient groups that doesn't benefit from this trial because, they excluded them, that they're not symptomatic. They don't fall into these criteria. So for patients with symptomatic HIF-ref, there was a significant benefit towards a reduction of heart failure events, CV mortality, and other objective health measures. And so these are all objective health measures because they're clinical signs that we can collect, being an A1C, serum creatinine, BMP, systolic blood pressure. Questionnaires are probably half subjective when compared to placebo for many relevant subgroups. All my references that I mentioned throughout the talk are listed below, and if you have any questions for me, let me know. If nothing else, this has been Healthy But Whole. Thank you for your time.